Good afternoon, students. I'm going to start lecture anomalies of amniotic fluid. This is the first part of my presentation, and the second part is going to be multiple gestations, what is related to this topic. Let me introduce myself. I am Dr. Igor Lifshitz, Associate Professor of the Chair of Obstetric Gynecology and Perinatology #1 of our medical academy. So let's start from a little bit of physiology. Physiology of amniotic fluid, that is watery fluid that surrounds the fetus, which is in amniotic sac inside the uterus. Amniotic fluid is produced by placenta and membranes in early pregnancy, and of course the composition of it is fetal kidneys and fetal lungs in late pregnancy. On the other hand, amniotic fluid is absorbed by fetus during swallowing, skin absorption, and gastrointestinal absorption, as long as with lung absorption. The amniotic fluid is necessary for the baby, for the fetus inside the uterus, for its proper growth and development. It is the environment of the baby. Also, amniotic fluid cautions the fetus from physical trauma, which may be possible during the whole time of gestation. And of course, amniotic fluid permits lung fetal growth and helps to maintain fetal temperature inside the uterus. Also provides a barrier against the infection. Very often question what's the normal amount of the amniotic fluid, because we will speak about the increased number of amniotic fluid and lower level of amniotic fluid. But it's different in different patients, in different women, in different pregnant women. The average volume increase with gestational age, and it's obvious, peaking at around 1 liter, which coincides with 36-39 weeks of gestation. In near-term, fetus produce around 1,200 milliliters of urine and swallows between 280 milliliters of amniotic fluid per day. On this graph, you see that at early time of gestation, the amount of amniotic fluid is up to 20 milliliters, and it gradually increases about late term of gestation. But when the amount of amniotic fluid is increased abnormally, we call this condition as polyhydramnios. And that alerts the clinician to possible fetal anomalies. In pregnancies affected by polyhydramnios, approximately 20% of neonates are born with some congenital anomalies. Therefore, the delivery of these newborns in tertiary care centers is preferred. On the other hand, when the amount of amniotic fluid is diminished, we call this condition as oligohydramnios. Oligo from Greek word means less, not a lot. Results in poor development of the lung tissue and other conditions, and can lead to fetal death. This slide pictures you the balance of amniotic fluid, which is, I mentioned before, produced by placenta, by membranes, by kidneys, so baby urinate, and swallowing of the fluid helps to maintain the balance, and absorption of the skin and lung tissues is necessary for absorbing it. Rupture of membranes is the most common cause of oligohydramnios. However, because the amniotic fluid is primarily fetal urine in the latter half of the pregnancy, the absence of fetal urine production or the blockage in the fetus urinary tract can also result in this condition. Also, fetal swallowing, which occurs physiologically, reduces the amount of fluid. So if baby swallow more fluid than it should be, this also can lead to oligohydramnios. On the other hand, if baby swallowing is a problem, or blockage of the fetus gastrointestinal tract is in place, that may lead to polyhydramnios. The volume of amniotic fluid can be assessed by specific instrumental methods such as ultrasonic technique, ultrasound imaging, visually dividing the mother's abdomen into 4 quadrants is done. The largest vertical pocket of fluid is measured usually in centimeters. The sum of this measurement is the amniotic fluid index, AFI. Although it is a subjective method, it is necessary to measure to assess fetal well-being, growth, and development of the baby. Let's come back to one of the measurements, which we call maximum vertical pocket measurement, or single deepest pocket, SDP. It is usually used in single pregnancies less than 24 weeks of gestation, so before the 3rd trimester of pregnancy. How can we measure it? We need to find the largest pocket of amniotic fluid while doing ultrasound examination, free of cord, free of umbilical cord, and free of fetal parts. We need to measure the greatest vertical dimension with the ultrasound transducer perpendicular to the uterus. Normal measurement of the maximum vertical pocket is 2 to 8 centimeters. It is shown on the slide. See, we are holding the probe perpendicular to the abdomen, and on the screen of the ultrasonic machine we see the amount of fluid free from small parts, from umbilical cord, and can measure this distance. So again, the normal measurement of the maximum vertical pocket is from 2 to 8 centimeters. Also, this AFI, or amniotic fluid index, which we usually do in the 3rd trimester, 24 plus weeks, and especially we also utilize this method in case of twin gestation. As I mentioned before, we need to divide the uterus into 4 equal quadrants. Again, we need to measure the deepest vertical pocket of fluid in each quadrant. Pocket should be free of cord and fetal parts, again. And then we sum these 4 measurements together. We plus to each other. Please watch the video.
All right, now let's assess fluid. So again, in our initial assessment, we noticed that the fluid looked normal just visually, but people like measurements, and we're going to talk about doing an AFI properly. So we want to divide the stomach up into 4 quadrants, a line down the middle, and across the belly button here. We'll begin in the upper left-hand quadrant, doesn't matter where you begin. People ask me, should I take this measurement in a transverse plane or a longitudinal plane? And the answer is it doesn't matter as long as you're perpendicular to mom. This is an AP, anterior to posterior measurement, so whether you're longitudinal or transverse, it's the same plane. So we find a nice pocket of fluid. And a couple things to keep in mind is to not put too much pressure on mom, because you can squish the pocket. You can see visually when I put pressure, I'm making it a smaller pocket. When I release pressure, that's a nice big pocket, and this is a more accurate measurement. So that's one thing to keep in mind. Another thing to keep in mind is to not have your gain too low. If you have your gain too low, you can miss chord, and you can actually include some umbilical cord in your measurement, which is incorrect. So you want to turn your gain up enough to be able to see chord. Another trick with the chord is to put on color. So Elizabeth's images very nicely, so I can clearly see where the chord is, but as the pregnancy progresses and the fluid gets naturally less and less, there's going to be more chord, and to distinguish it, it's always a great idea to put on color. And so I can see here that that's a big pocket without chord. Another question people ask is measuring a pocket of fluid with an umbilical cord within the pocket. And it's okay to measure the pocket with cord in there, but you can't include the cord in your measurement. So for instance, in this pocket you can see that there is cord, but when I measure, I'm going to count. When I measure, I'm not going to include the cord within the measurement, but it's okay that it's in the pocket. So that sometimes that's confusing to people. So I'll take that picture, and then I just maintain this perpendicular position with the transducer and scan down. Remember not to put too much pressure. You see, I can increase the pressure and just totally reduce the amount of fluid in that pocket. So when I let off pressure, this is a nice pocket. Again, add my calipers. So I've done left upper quadrant, left lower quadrant, and right lower quadrant. Here, nice pocket. Count Q3. And then up to the left upper quadrant. So again, here I see chord in the image, so I want to make sure, put some color on just to be safe. That's where her cord is entering her placenta, which is a real peripheral insert there, so keep an eye on that. And I just want to angle down a little bit to get the cord out of position. I don't want to include it in that measurement. So what I'll do here is I'll actually take the measurement like this. I don't want to include that cord. So our AFI is 10, which is normal. I could actually get this a little bit better by coming up further. And again, here's a nice image of this reverberation artifact. You can see it in the near field here. So to get rid of that artifact, you can reduce your gain, or you can just reposition. As I come down a little bit, then you'll see that artifact will go away. This is actually a better pocket than the one I was going to originally take. Q4. Put it like that. So 11.5, very normal. And again, keep in mind that this is a subjective measurement. The baby moves. You want to try to get this measurement done in rapid succession, so you don't wait minutes between taking one quadrant and the next, because the baby will move and it'll incorrectly measure her AFI. But overall, just keep in mind those few things that don't have your gain too low. Use color if you need to. Keep your probe perpendicular, and your measurements in a true AP. And that's your AFI.
Well, so I hope you heard very well what the doctor described while doing AFI. She measured in different quadrants, 4 quadrants, and she added some numbers. So, and from 5 to 25 centimeters, their amniotic fluid index should be considered normal. If it is less than 5 centimeters, it should be considered as oligohydramnios. When it is more than 24 centimeters, it must be thought as polyhydramnios condition. So let's speak about the latest one. Polyhydramnios, a pathological condition which is characterized by excessive accumulation of amniotic fluid more than 1.5 liters in the amniotic cavity. It may be acute or chronic. Visual inspection may reveal a rapidly enlarging uterus in the pregnant mother. Multiple gestations, of course, may be associated with polyhydramnios. Abnormalities in fetal movement are suggested of primary neurological abnormalities and may be association with a genetic syndrome such as polyploidy. Ultrasound usually of help, and as we mentioned before, 24 centimeters and more in a is considered to be a polyhydramnios. Or if you do a single pocket fluid measurement, it should be at least 8 centimeters in depth. Usually polyhydramnios is considered when more than 2 liters of amniotic fluid is located inside the amniotic cavity. Here is the data according to MVP, single pocket measurement before 24 weeks. So if it is more than 8 centimeters to 11 centimeters, it is considered to be mild polyhydramnios. If it is moderate polyhydramnios, the number is between 12 and 15 centimeters in the single pocket. If you measure amniotic fluid depth more than 16 centimeters, it should be considered as a severe polyhydramnios. This is the example of AFI measurements. When you see the collection of fluid is much more than it should be, 36 centimeters is AFI, so it is a polyhydramnios. You see this measurement is very big one. This is long distance, this distance is very long, and as well as the last one. So AFI is 36 and even some more centimeters. What can be done also in not only ultrasound, glucose tolerance testing for mothers with suspected type 2 diabetes mellitus. If hydrops fetalis is present, immunologic and fetal infection need to be investigated. This should include screening for maternal antibodies to DC, Cal, Duffy, and KID antigens to determine maternal antibody production against the fetal red blood cells, erythrocytes. Of course, test for syphilis is necessary. Torch infection evaluation is necessary. Test for congenital viruses may be proven by PCR testing of amniotic fluid, which you can obtain by using amniocentesis procedure. Kleihauer-Betke test from mother blood is useful for evaluation of fetal maternal hemorrhage, which may occur in cases of Rh incompatibility. Hemoglobin BART in patients of Asian descent who may be heterozygous for alpha thalassemia can be investigated. And fetal karyotyping for trisomy 21, 13, and 18 sometimes is done for evaluation of chromosomal aberrations of the fetus. During ultrasound investigation, the specialist must evaluate the fetal swallowing. It can be seen while doing this investigation. So a decrease in fetal swallowing occurs in case of anencephaly, Down syndrome, Edwards syndrome, Patau syndrome, in case of muscular dystrophy and skeletal dysplasia. Also, we evaluate the fetal anatomy, especially pay attention to diaphragm, any masses, tumors inside the lungs, and absence of the stomach bubble, which is associated with esophageal atresia. The double bubble sign or dilated duodenum suggests the possibility of duodenal atresia. Tests for fetal arrhythmias and for malformations that result in cardiac failure and heat drops. An abnormal large abdominal circumference may be observed with ascites, collection of fluid inside the fetal belly, and hydrops vitalis. Large babies, large fetuses can be observed and associated with poorly controlled maternal diabetes. Assess the blood flow velocity in the fetal middle cerebral artery to predict or consider fetal anemia. What is the etiology of polyhydramnios is depicted on this slide. And I mentioned before that twin gestation is one of the cause of this condition, especially with these monochorionic twins, and twin-to-twin transfusion syndrome can be found in this case. Fetal anomalies, like I told you before, CNS abnormalities and neuromuscular diseases can cause swallowing dysfunction of the baby. Congenital cardiac rhythm anomalies can be associated with hydrops on fetal to maternal hemorrhage and parvovirus infection. Diabetes mellitus, which is poorly controlled, another option. RH incompatibility, chromosomal abnormalities, as I mentioned before, fetal akinesia syndrome with absence of swallowing. It was found by Coleman with his team that they investigated 860 singleton pregnancies which were complicated by polyhydramnios, and 2/3 of these were cases of the idiopathic polyhydramnios, no obvious cause of it, whereas maternal diabetes was found in up to 20% of cases. Congenital anomalies in 8.5%, and positive torch serology was in up to 3% of the patients. What is the prognosis in those patients? If it is not associated with findings, so idiopathic polyhydramnion, their prognosis usually is good. Anyway, some authors reported 61% of perinatal mortality associated with fetal or placental malformation. About 20% of infants with polyhydramnios have some type of anomaly. In these cases, their prognosis depends on the severity of the anomaly. Yefet and his team reported that even with normal, detailed prenatal ultrasonic evaluation, polyhydramnios is associated with increased rate of fetal malformation, genetic syndromes, neurologic disorders, and development delay. In study of 163 women with idiopathic polyhydramnios, resolution was more likely when it was diagnosed early in pregnancy and when the AFI was low. When idiopathic polyhydramnios persist across the whole pregnancy, the time of whole pregnancy, there was an increased risk of macrosomia, large baby, and preterm delivery. As the severity of polyhydramnios increases, the likelihood of determining the etiology increases. You see that only about 16.5% of mild polyhydramnios may have significant problems. But polyhydramnios itself occur not a lot of pregnancies, only about 1% of pregnancies. But on the other hand, its counterpart, oligohydramnios, occur about 11% of pregnancies. So we need to keep in mind that oligohydramnios you can find more often than polyhydramnios. The perinatal mortality rate is increased to 4 deaths per 1,000 patients with polyhydramnios and 56 deaths of babies per 1,000 patients with oligohydramnios. So oligohydramnios should be considered more severe condition comparing to polyhydramnios and more often be met. Anyway, complications of polyhydramnios may include prolonged first stage of labor. They may also lead to non-vertex presentation, which is not favorable, like breech presentation, and of course may lead to abdominal deliveries. Preterm labor delivery occurs in approximately 26% of mothers with such condition. Other complications may include premature rupture of membranes, malpresentations of fetus, cord prolapse, abruption of placenta, postpartum hemorrhage, amniotic fluid embolism, maternal respiratory distress, increased maternal uterine tone, and transitioned fetal respiratory distress. Fetal-maternal hemorrhage, maternal RH sensitization and incompatibility, fetal pneumothorax. And of course, risk of fetal infection, intrauterine fetal infections, is increased. 20% of cases with poly associated with fetal anomalies, including problems with gastrointestinal system, 40%, CNS, 26%, cardiovascular system of the baby, 22%, and genitourinary system, 13%. Among those cases of multiple gestation occurred around 7.5%, and 5 are due to maternal diabetes. The remaining 8.5% were due to other causes. However, at least 50% of patients had no associated risk factors, so-called idiopathic polyhydramnios. What can we do with such patients? Reductive amniocentesis may be performed and has contributed to prolonged pregnancy in patients who are severely affected by polyhydramnios. This procedure can reduce the risk of preterm labor, PROM, umbilical cord prolapse, abruption of placenta. However, too much fluid is removed during this procedure of amniocentesis. Placental abruption may occur anyway. Other complications of the procedure of amniocentesis include inflammation, like infection, which is caused by infection, bleeding, and very rare trauma of the fetus by the needle. Second option include laser ablation of the placental vessels, but it is effective only in cases of twin-to-twin transfusion syndrome, which we will talk about later on. Let's come to another part of it's oligohydramnios. I already a little bit touched this topic. Should be considered more difficult condition comparing to polyhydramnios and more often to be seen. In this case, less than 0.5 liter of amniotic fluid is anticipated. A complete absence of amniotic fluid is called as anhydramnios. No fluid, no amniotic fluid. Primary or idiopathic and secondary oligohydramnios are distinguished by the doctors. What can cause this condition? Obviously, fetal urinary tract anomalies such as renal agenesis, polycystic kidneys, or any urinary obstructive lesion, for example, posterior urethral valves of the baby. Trauma, premature ruptures mid-brain, and chronic leakage of amniotic fluid is a common cause of it. The next is inflammation of chorion and amnion, which is called chorioamnionitis. One of the important maternal complications because of ruptured membranes or ascending infection from the vagina through the cervix. The earlier chorioamnitis occurs in pregnancy, the greater the fetal risk of bronchopulmonary dysplasia, neurologic complications, pulmonary hyperplasia, and in severe cases, respiratory failure of the neonate. The next possible cause is placental insufficiency, as seen in pregnancy-induced hypertension, maternal diabetes, post-maturity syndrome when the pregnancy extends beyond 42 weeks of gestation. Maternal use of prostaglandin synthetase inhibitors or angiotensin-converting enzyme preparations for treatment of hypertension, for example, is maybe the cause of oligohydramnios. Maternal body mass index does not appear to be associated with oligohydramnios in late gestation. What can you find in patients with oligohydramnios? The uterine fundus height is less than it should be. So if you follow your gravitygram, the graph which you put dots to different weeks of gestation, you see that the fundus height is less than it should be. But of course, again, ultrasonography plays the major role for detecting and proving this condition. So AFI should be less than 8 centimeters and or the absence of fluid pocket 2-3 centimeters in depth. Look at this picture, this photograph of the ultrasound. You see AFI is less than 4 centimeters, which denotes that this patient has oligohydramnios, so no amniotic fluid around baby. Usually oligohydramnios is a symptomatic condition. Uropathies cause similar deformations, including external compression with a flattened fascias and epicanthal folds, hypertelorism, low-set ears, a so-called mongoloid slant of the palpebral fissure, a crease below the lower lip, and micrognathia. Of course, thoracic compression may occur for the baby. Oligohydramnios adversely affect fetal lung development, resulting in pulmonary hyperplasia that typically leads to death from severe respiratory insufficiency. Because amniotic fluid is necessary for lung maturation, although baby doesn't breathe in and out while during gestation period. Fetal deformations may include bowed legs, clubbed feet, a single umbilical artery syndrome, gastrointestinal atresias, and narrow chest secondary to external compression. Infants are typically small for their stated gestational age. When abdominal mass is found on examination of the infant in the clinical setting, it is often represents multicystic dysplastic kidney, enlarged urinary bladder, and prune belly syndrome. One of their complication is the so-called Potter syndrome. You can remember it by mnemonics rule. P stands for pulmonary hyperplasia. O is oligohydramnios, which we are discussing now. Twisted faces, twisted skin, extremity may be deformated, and renal agenesis occur. So this syndrome usually have dramatic complications for the baby, for the neonate. Lack of amniotic fluid allows compression of the fetal abdomen, which limits movement. In addition to chest wall fixation, the lack of amniotic fluid flowing in and out of the fetal lung leads to pulmonary dysplasia, which is in case of Potter syndrome. Oligohydramnios is also associated with meconium staining of the amniotic fluid. You remember that meconium is the primary stool for the fetus. Fetal heart conduction abnormalities, cord compression. Babies usually tolerate poorly the process of laboring. Usually those baby delivered with the low Apgar score, and fetal acidosis also is present. In cases of intrauterine growth restriction, the degree of oligohydramnios is often proportional to growth restriction, is frequently reflective of the extent of placental dysfunction, and is associated with corresponding increase in the perinatal mortality. Some primary complications of oligohydramnios are those related to fetal distress before or during labor. And of course, risk of fetal infection is increased in case of oligohydramnios connected with prematurely ruptured membranes. Again, maternal body mass index does not appear to be associated with oligohydramnios in late gestation. What is the prognosis for such patient? It depends. The prognosis is related to the volume of amniotic fluid. Borderline oligohydramnios, less than 8 centimeters to up 5 centimeters AFI, does not appear to be of high risk for adverse perinatal outcomes. In case of oligohydramnios with renal agenesis, mortality of the baby is almost 100%. Milder forms of renal dysplasia or obstructive uropathy can be associated with a mild to severe degree of pulmonary hypoplasia and long-term renal failure. In cases of pulmonary hypoplasia, the effectiveness of many treatments, such as administration of surfactant, high-frequency ventilation, CPAP, nitric oxide, has not been established yet. In the settings of oligohydramnios, testing of the infant is recommended, depending on the result of postnatal evaluation of the infant. It may include chromosome testing, karyotyping the baby, testing for evidence of congenital infection, ultrasonography of the genitourinary tract, and appropriate radiological evaluation of the GI tract. Electrocardiography and echocardiography may be also indicated. Very useful information may be given by histological examination of the placenta, in both cases in oligohydramnios and polygohydramnios as well. So again, PROM is the most common cause of oligohydramnios. Maternal substance abuse and certain medication like non-steroid anti-inflammatory drugs. AAC1 also can cause oligohydramnios, as I mentioned before. Please test those patients for systemic lupus erythematosus, SLE, which may cause immune-mediated infarcts in the placenta as well as the placental insufficiency. It's necessary to evaluate the patient for pregnancy-induced hypertension, preeclampsia. HELP syndrome is one of the variety of it. Of course, elevated blood pressure, proteinuria, elevated enzymes, and low platelets, they may lead to these diagnoses. Serial measurements of the amniotic fluid index during the pregnancy is necessary. So don't use just once ultrasound for detecting or suspicion of this condition. If the mother is in the third trimester and FI is less than 8 centimeters, suspect oligohydramnios, but level below 5 centimeters indicates significant oligohydramnios. Their specialist must visualize the fetal kidneys, collecting system of the urine and bladder. If these are normal, you need to suspect chronic leakage of amniotic fluid or pregnancy-induced hypertension, which is very common. Of course, you need to assess fetal growth. If premature rupture of membrane or urinary tract anomalies are absent, consider placental insufficiency. So you may think about that placenta doesn't produce normally amniotic fluid, or maybe intrauterine growth restriction, which is also connected with placental insufficiency. Less oxygen, less necessary substances go to the fetus. While doing ultrasound, it's necessary to utilize Doppler study, which may aid in the diagnosis of placental insufficiency. After birth of the baby, evaluate organ systems likely to be involved on the basis of the pregnancy history and result of prenatal evaluations. So what can we do with such patients? We may use instillation of dye, indigo carmine, to evaluate the premature rupture membranes. So maybe the leakage we can see with this special substance, which is again name is indigo carmine. So if you see that from the cervix to the vagina some blue colored dye, that means that prom may be in this patient. If it is not diagnosed, the transcervical instillation of isotonic sodium normal saline, this procedure is called amnioinfusion. So you inject via needle through the abdomen to the amniotic cavity normal saline, especially at time of delivery. It may reduce the risk of cord compression during their labor and fetal distress and meconium dilution. It also reduces the potential need for abdominal delivery, cesarean section. Consider hospitalizing such patients if oligohydramnios is found after 26 of gestation. If fetus doesn't have an anomaly, delivery should be performed if the biophysical profile is non-reassuring, immediate delivery. The installation of isotonic sodium chloride in the second trimester may be benefit in some patients. Amnioinfusion, which I mentioned before. In case of associated with post-maturity, review the pregnancy dating. Maybe you are wrong, maybe your colleague was wrong while calculating their number of weeks of gestation. If meconium is present during labor, administer amnioinfusion therapy to reduce the potential for fetal distress and prenatal aspiration. And transfer those patients to a tertiary healthcare center when they have a high likelihood of maternal illness, preterm delivery, and infant problems that may require proper resources of the healthcare system. The first step is identifying the cause, the etiology of oligohydramnios. And medical care also includes the use of steroids to enhance fetal lung maturation if you anticipate premature delivery. Patients with polyhydramnios tend to have a higher incidence of preterm labor secondary to overdistension of the uterus. So schedule them weekly or twice weekly for prenatal visits and cervical examination. You need to place patients to bed rest, serial ultrasound examination. In case of polyhydramnios associated with fetal hydrops secondary to fetal anemia, the direct intravascular transfusion of erythrocytes may be done. In case of polyhydramnios in which maternal diabetes is suspected, you need to perform a glucose tolerance test and to control these diabetes in case you will find it. So you need to give a proper diet, less carbohydrates, and insulin sometimes as needed. Most cases will respond for the first week of treatment with indomethacin, which is non-steroidal anti-inflammatory drug. But if it is caused is not hydrocephalus or neuromuscular disorder that alerts fetal swelling. Management for oligohydramnios patients includes maternal bed rest and hydration as possible. You need to control blood pressure of the patient. If pregnancy-induced hypertension anticipated. Studies showed that oral hydration by having the women drink 2 liters of water increase the AFI by 30%. In single pregnancies where oligohydramnios is present without maternal fetal complications, evidence exists that either oral or intravenous maternal hydration is associated with improvement for AFI and reduction of cesarean section rate. Further studies are necessary, of course, to determine if corresponding improvement in fetal and neonatal well-being can be sustained with such forced hydration therapy. Sometimes you need to consult your colleagues, especially when the condition is unexplained, when it involves hydrops fetalis or associated with congenital malformations, especially in this case you need a geneticist counseling. So you need to invite neonatologist or pediatric surgeon, cardiologist for the babies, nephrologist, pediatric infection disease specialist, or the genetic specialist may be required for appropriate evaluation of this patient, fetus, and the newborn later. We can continue with the multiple gestation now. Development of 2 and more embryos in the uterus is termed as a multifetal gestation. Development of 2 fetuses, whether through monozygotic or dizygotic fertilization, is known as twin gestation. Pregnancy with 3 fetuses is referred to triplets, 4 quadruplets, and so on. Pregnancies complicated by multiple births are associated with high rate of neonatal morbidity and mortality, paralleling in increased risk of preterm delivery, low birth weight, and other associated high-risk conditions. Maternal morbidity and mortality are also increased in pregnancies complicated by multiple gestation and multiple births. What's the etiology of the multiple gestation? The possibility of fertilization of 2 and more eggs created by a number of reasons. 2 or even 3 follicles can be simultaneously ripen in the ovary that makes ovulation of not 1 but 2 or more oocytes possible. Ovulation can occur simultaneously in both ovaries, so 2 and more oocytes are capable for fertilization. Each mature follicle can contain, rarely but can contain 2 oocytes at the same time. Also, twins may result from a typical process of cell division. Some investigators found hereditary or family predisposition for this condition, and now infertility and ART treatment is in charge of multiple gestation in many cases. We'll speak later about zygosity and chorionicity. The incidence of monozygotic twins, approximately 4 per 1,000 births. Approximately 2/3 to 3/4 of twins are dizygotic. So birth rates of dizygotic twins vary by race. We see it more often in black population. 7 to 10 per 1,000 births in white people, and approximately 3 per 1,000 births in Asian people. And it depends on maternal age. The frequency has risen with increasing maternal age less 40 years of old. Naturally occurring triplet births occurs approximately 1 per 7,000, 10,000 births, and naturally occurring quadruplets births occur approximately 1 per 600,000 births. I'm saying naturally occurring because conception may be done with the use of assisted reproductive technologies like IVF or ICSI. Look at this graph. You see that in the United States the twin birth rate is increased from, let's say, 18 to 1,000 live births to 34 in 2010, and no decline still now. Placental physiology is of paramount importance of neonatal outcome. Monochorionic twins have increased neonatal morbidities such as prematurity, intrauterine growth retardation, congenital anomalies, twin-to-twin syndrome, increased perinatal mortality. Triplet gestation with monochorionic placentation may also experience an increased complication rate. So, chorionicity and amnionicity. Early in multiple pregnancies, an ultrasound exam is done to find out whether each fetus has its own chorion and amniotic sac. So it must be done as early as possible. There are three types of twins: dichorionic diamniotic, monochorionic diamniotic, and monochorionic monoamniotic, mono, or momo, sometimes it's called. You see the description of each of these variations. So again, dichorionic diamniotic, monochorionic diamniotic, and monochorionic monoamniotic. Let's see in this picture. You see that the mainly twins are developing from dizygotic fertilization, 2 eggs, 2 sperms, and it gives diamniotic, dichorionic development. There 25% of twins will be identical twins, which means that they developed from one oocyte and one sperm. But you see the difference of the dichorionicity and monochorionicity depends on the time of their division of cells. And sometimes you see if the division of cells occurred in 2 weeks, it may lead to conjoined twins, very extremely rare condition. This is very important to know chorionicity because their delivery and mode of delivery may be different because of this condition. And on the ultrasound, which is of help in this situation, you may see different signs, like lambda sign to the left. You see lambda sign, it's from Greek letter lambda, and a T sign So it's like inverted letter T. So in case we see lambda sign in case of dichorionic diamniotic twins and monochorionic diamniotic twins. So these two amnions here between here and here, and you see this is usually in monochorionic diamniotic twin. So chorion or placenta is 1 and 2 amnion sacs. In this picture you see the position of the placenta in case of dichorionic and monochorionic presentation. Again, this is letter A depicts dichorionic diamniotic placentation, and with two absolutely separate placentals location, they are not joined. And B is the same, but placentas are conjoined, it's okay. And this is monochorionic twins. You see the monochorionic development, and the difference is they have those twins. They have septum between them, so it is monochorionic diamniotic, and this is monochorionic monoamniotic, momo twins. In placentas with dizygotic twins may fuse if the implantation sites are proximate. Triplet pregnancies result from various fertilizations, splitting, and development scenarios that involve ova and sperm. For example, triplets may be monozygotic, dizygotic, or even trizygotic. Zygosity in quadruplets and higher order multiplets also may vary. Although the evaluation of the placentas following birth is important in all multifetal pregnancy, the examination may not always help to understand that zygosity. Most pregnancies are prenatally diagnosed and must be diagnosed prenatally. Maternal complaints of excessive weight gain, hyperemesis gravidarum, vomiting, throwing, nausea in case of pregnancy, the sensation of more than one moving fetus sometimes can be told by mother, the use of ovulation-inducing drugs in anamnesis, or family history of twins should alert healthcare provider to use possibility to think about the possibility of multifetal pregnancy. Women with multifetal pregnancies may have a uterine size that is inconsistently large or larger for dates and may experience accelerated weight gain. Upon auscultation, more than one fetal heart rate may be heard. One to the right, one to the left, one to the up, one to the down. And you see on the picture the mother's belly is markedly enlarged in case of 33 weeks of pregnancy, roughly corresponding to the full-term gestation in a singleton pregnancy. And those changes you can maybe see if you do surveillance for the obstetrical monitoring of their future mom. You see the growth of the abdomen is much more than in a singleton pregnancy. Also, you need to remember that those patients, those women, they require better nourishment, better food, and so extra 300 calories per day is needed for each fetus. So ultrasound examination is very important as in any gestation, and especially in multiple gestation. In the first trimester, ultrasound is based on revealing 2 or more gestational sacs. You can find it even in the early term of gestation, like 6 weeks of gestation. Ultrasound examination during the 2nd and 3rd trimester is considered authentic at reception of one projection of images of 2 or more embryos, heads, trunks, and buttocks of the fetuses, determination of fetal positions, and so on. The additional instrumental methods of examination are phono and electrocardiography of each fetus, cardiotocography, and fetal MRI sometimes is useful for detection of fetal anomalies. On this MRI, you see three fetuses. 1 and 2 are here. This is T2 weighted examination of D chorionic, 2 chorions, 2 placentas, and 3 amniotic triplet gestation. The evaluation of multifilial pregnancy involves routine prenatal and postnatal care, as well as specific assessment directed by the type of multiple pregnancy and neonatal complications. Usually routine prenatal laboratory studies are necessary to be done. Procedures are very specific to the obstetric and neonatal complications. As I mentioned before, laser ablation procedure for twin-to-twin transfusion syndrome are quite rare. Intrauterine surgery in case of conjoined twins, extremely rare. Obstetric medical care is specific to type of multifilial pregnancy. The highest risk is considered for monochorionic, monoamniotic pregnancies. An inherent risk of other conditions like preterm labor, intrauterine growth retardation, hypertensive diseases is also found in multiple pregnancies. For pregnant women with multiple pregnancy, hospitalization in maternity department at least to the second, third weeks prior to prospective term of delivery is necessary for examination, planning tactics of delivery and labor, and preparation for it. Maternal complications include spontaneous abortion, anemia, maternal anemia, because there increased iron requirement by 2 fetuses, fatty liver of pregnancy. It is rare, but it may occur. Hyperemesis gravidarum, nausea and vomiting. Severe cases may be seen in case of twin and multiple gestation cases. Polyhydramnios, which we discussed before. Pregnancy-induced hypertension and preeclampsia. Placenta previa, maybe because the increased placental size and chance of placental enrichment upon the lower segment of the uterus. Antepartum hemorrhage. Preterm labor, usually minus 2 weeks from the term for each extra child. Varicosis of the venous and edema. Usually the course of labor of twins does not differ from the course of labor in singleton pregnancy. In half an hour after delivery, the first baby the membrane of the second fetus may rupture and delivery of the second fetus is done. The placenta or 2 placentas may be delivered then. So the first and third stages in twin gestation are common for both fetuses, but the second stage is of each of them are done separately, of course. In rare cases, the period of expulsion is also common for the twins that usually result in serious complications in delivery. Also, you need to understand that babies or fetuses may be located differently inside the uterine cavity. So they may lie in vertex, and also combination may be vertex-breech and breech-vertex, and breech, and maybe vertex transverse or breech transverse, as it's showed on the picture to the right. So if it is vertex to vertex twins presentation, a trial of labor is generally accepted in this situation. Caesarean delivery is usually indicated in the presence of non-vertex twin presentation, monoamniotic twins, when one amnion, a higher order multiple gestations, triplets, quadruplets. For the vertex, non-vertex twin presentation, several options are available, including caesarean delivery for both of twins, attempted cephalic version of the second twin, or a breech extraction of the second twin. But if it is the first baby is breech position, there caesarean delivery is usually recommended. Twin gestation and twin delivery should be considered as a high risk obstetrics because fetal malpresentation you may see more often, vasa previa, cord prolapse can be seen more often, premature separation of the placenta, abruptio of placenta, cord entanglement around the neck of one of the baby. Postpartum hemorrhage is maybe seen more often. Dysfunctional contractions, discoordinated labor activity, and increased operative interventions are seen more often. In 30–40% of women with twins, labor starts prematurely. In 10–30% of women, discoordination and or weakness of labor activity, protraction disorder is observed. Prom happens in 15–30% of patients. Prolapse of small parts of the fetus and umbilical cord may occur in up to 8% of cases. So development of dystocia, difficult labors, difficult labor is connected with overdistension of muscles of the uterus and anterior abdominal wall, the decrease of its contractility in connection with presence of 2 or more placentas also can increase the size of the placenta, and so on. Complications of the second stage of labor is obvious. The process of expulsion of 2 fetuses requires more time and more expertise for the obstetrician, by the way. The transverse and oblique lie of the second fetus is encountered 5–10 times more often, and breech presentation 8–10 times more often than at pregnancy with 1 fetus. All this indicates incidence of urgent operative delivery or maneuvers, and prolonged second stage of labor represents serious danger for mother, mother trauma, mother infection, and fetus asphyxia. One of severe complications in this stage of labor is abruptio of placenta before delivery of the second fetus. So the doctor must be prepared for such complications. Again, the third stage of labor and early postpartum period is maybe complicated with hemorrhage, massive hemorrhage. You need to control the complete expel of the placenta. So you need to control the wholeness and determine the chronicity. And for prophylactic of hemorrhage, usually methyl ergometrine is administered subcutaneously at the time of this second stage. Uterine subinvolution is more common in such patients. Infection, inflammatory diseases, failure of lactation is very often seen. Prematurity is the most frequent neonatal complication. The baby are born pretermly. Hypothermia for the babies, which may lead to respiratory difficulties, intracranial bleeding, hypoglycemia, necrotizing enterocolitis, infections, and retinopathy of prematurity. Congenital anomalies, this is more often seen in case of monozygotic twin pregnancies. Monochorionic twins Monochorionic monoamniotic twins have a common placenta with possibility of significant vascular communication between 2 fetal circulations. These twins may develop twin-to-twin transfusion syndrome. Diagnostic consideration for this syndrome, it is to find polyhydramnios of 1 twin and oligohydramnios in the second one. Chronicity is the best defined by ultrasound before 14 weeks of gestation. The earlier is the better. Monochorionic twin gestation should be screened for TTS every 2 weeks starting from 16 weeks and continue until delivery. Growth scans should be concomitantly be performed every 3–4 weeks to detect growth failure. Monochorionic placentas have anastomotic vascular connections between the twins. These anastomosis can be artery to artery, vein to vein, or artery to vein. Vasoconstriction leads to uteroplacental insufficiency and intrauterine growth restriction of the donor twin. Blood flow is redistributed to protect the brain, and vasoconstriction results in abnormal umbilical artery by the Doppler studies. The donor twin may develop hydrops because of severe anemia. If TTS is left untreated, mortality is 80–100% in severe cases. Fetal death of one of the twin is associated with neurological sequelae in 20% of surviving twins. Fetal blood pressure instability can lead to brain ischemia in either the donor or recipient. So both twins are suffering in this case. Periventricular leukomalacia, porencephaly, microencephaly, and cerebral palsy have all been identified by survivors of this syndrome. What is the treatment of this syndrome? It is recommended to do fetoscopic laser photocoagulation, to clip with the laser use dose anastomosis, selective photocoagulation. Sometimes amnioreduction can be done to reduce hydrostatic pressure of the smaller twin. Septostomy, so to create a hole between the inside the septum, allows equilibration of hydrostatic pressure and relieves the compression of the placenta with the donor twin. Meta-analysis showed survival was improved in the remaining twin if selective cord occlusion was performed after 18 weeks of gestation. The next problem with twins is considered vanishing twin syndrome, or single intrauterine fetal death in case of twins. It's not that often, but it may happen. Usually it is demonstrated that increased risk of death of co-surviving twin after the death of the first twin was 12% for monochorionic pregnancies and only 4% for dichorionic pregnancies. So it's very important to remember to know chorionicity. The odds ratio for monochorionic co-twin intrauterine death was 6 times that of dichorionic twins. No development delays in children up to 1 age when comparing to surviving twins from a vanishing twin pregnancy and children was noted. After the first trimester, the overall incidence of single twin death after is estimated between 2.6 and 6.2%. The multiple causes for fetal death in twin pregnancy include fetal chromosomal or congenital malformations, maternal diseases like diabetes mellitus, placental diseases. Twin pregnancies complicated by fetal death are in increased risk for both preterm delivery and death of co-twin. And despite of chorionicity, most patients are managed conservatively during this period. After 24 weeks, the mode of delivery should be based on the obstetrical indication for either vaginal birth or cesarean section. The next complication for twin delivery, twin gestation, obviously, is the collision of twins, which may occur if it was a first breech and the second vertex baby fetus. You see on the picture, it is interlocking between heads of both fetuses, which is not allowed to deliver them vaginally, and is the indication for cesarean section. Both twins can get into a dangerous situation when they lie in a common cavity and due to absence of septum, because the umbilical cords of the fetus may interlace with each other and pace around the neck of each other, and arrested circulation of blood umbilical vessels may cause asphyxia of any of these twins. Thus, it is recommended to deliver such babies with cesarean delivery in case of monoamniotic twins, which are obviously monoamniotic, monochorionic. For high number multiple pregnancy patients, usually planned cesarean section is an option. Compare it with planned cesarean delivery, attempted vaginal delivery was associated with high risk of maternal transfusion, blood transfusion, and neonatal mechanical ventilation. Thus, it's safer to deliver triplets via cesarean section. And I'll touch a little bit on neonatal aspects that twin newborns usually develop in the same way as children born as in a single-term pregnancy. However, some newborns, physical and mental retardation may develop, and is more often manifested in premature infants and also in children delivered by mothers with complication of pregnancy. For example, pregnancy-induced hypertension, fetal placental insufficiency, and operative delivery was done. The impact of neonates from multi-fetal pregnancy on the family has been studied. Also, increased incidence of maternal depression, poor parent satisfaction with parenting, child abuse, and sibling behavior problems have been associated with multi-fetal pregnancy. Don't forget about this. And probably the last slide I wanted to show you, that is a supernumeric multiple gestation patient. It is well known, you can find it on the internet. Patient in the United States, she conceived out a IVF procedure. It was octuplet pregnancy, so big family for this lady. Her name is Nadia. And of course, now it's restriction in many countries where for IVF procedure to transfer not more than 2 embryos at the same time to prevent such complications. As I mentioned before, multiple pregnancy should be considered as a high-risk obstetric pregnancies for both mothers and neonates. This is all for now. Thank you very much for your attention. I hope you understand all the information well and it was clear to you, and you can discuss it during the practical lessons, classes, and seminars. Have a nice time. Bye-bye.